Good morning. Today we will talk about CNS infection. We try to cover the whole subject of CNS infection in 2 lectures. This is the first lecture. We try to cover some aspects of CNS infection when a bacteria or a virus or a fungus or a protozoa invades the brain parenchyma or the layers of the brain, which are called the meninges. Infection may be divided into meningitis, encephalitis, focal suppuration, or inflammation. What do we mean by that is whenever a virus invades the layers of the brain, which are the meninges, it's called meningitis. But when bacteria invades it, it has the same name. It's also meningitis. But when bacteria invades the brain parenchyma, it's called brain abscess or focal suppuration, while the virus is called encephalitis. Bacterial meningitis is caused by a primary infection within the subarachnoid space. So whenever an infection happens in the brain, it usually affects the subarachnoid space. That causes acute inflammation of the pia and arachnoid mater. Usually the pia and arachnoid mater are affected by the infection. This is called the leptomeninges. The incidence is about 2 to 6 per 100,000 per annum. It usually affects those who have a weak immune system, like infants or elderly. It may be divided into a variety of organisms, and according to the age and risk factor, the microorganism may differ. Bacterial infection reaches the CNS either by direct invasion, hematogenous, or embolization from an infected emboli. For example, a patient who has got chest infection or lung abscess. Also, infection may be iatrogenic, for example, after ventriculoperitoneal shunt, intracranial pressure monitoring, or surgery. Common causes of bacterial meningitis. This table shows us the common causes of bacterial meningitis according to the age and risk factor. If you notice that in neonates, the most common causes usually E. coli, group B streptococci, and Listeria monocytogenes. While in infants and children, usually the most common cause of bacterial meningitis, according to most of the textbooks, is Neisseria meningitidis. Other microorganisms include Streptococcus pneumonia, H. influenza. Adults, the most common microorganism that causes meningitis is Streptococcus pneumonia. It accounts for about 50% of all cases of bacterial meningitis. Elderly patients, whenever a patient becomes old or he has some immune compromised issue, for example AIDS or renal transplantation or malignancy, or patients who are on chemotherapy, apart from the above microorganisms, Listeria monocytogenes emerges. Listeria monocytogenes usually causes infection, as you noticed in this slide, in neonates and also in patients who have a weak immune. Whenever there is a fracture, a skull fracture, Staphylococcus becomes the most common cause. For example, after skull fracture or post-surgery, we see that Staph epidermidis, Staph aureus, gram-negative microorganisms like Pseudomonas, Proteus, Klebsiella, Acinetobacter. These microorganisms become the most common cause of meningitis. Remember that patients who have got fracture base of skull, if a patient develops fracture base of skull and CSF rhinorrhea, in such cases Streptococcus pneumonia is the most common microorganism. But if there is an open skull fracture, it is usually Staph. In pregnancy, always bear in mind that it may be caused by Listeria. Immune suppressed patients also remember Listeria apart from the other causes. We have rare causes also of bacterial meningitis like Salmonella, Shigella, Clostridium, Neisseria, and gonorrhea. Whenever we are first talking about the community-acquired meningitis, usually the transmission of the pathogen happens by respiratory droplets. Whenever there is a close contact, bacteria initially colonizes the nasopharynx by attaching to the epithelial cell using outer adhesive villi and membrane proteins. The risk of colonization of the respiratory epithelium is increased by damage caused by irritants such as a preceding viral illness or cigarette smoking. Bacteria then enters the bloodstream and gain access to the CSF via the arachnoid plexus epithelium or cerebral capillaries. What are the symptoms of bacterial meningitis? The symptoms of sign. Whenever you are in an emergency department, you receive a patient who has got a triad of fever, headache, and neck stiffness, you should suspect meningitis. The patient comes with fever, headache, and neck stiffness. It may be associated nausea and vomiting, photophobia, disturbance in the level of consciousness in the form of lethargy, stupor, coma. Seizure may happen. Seizure actually happens in 40% of patients who have got meningitis. This seizure could be generalized or partial. Generalized seizures usually happens due to derangement of the electrolytes. Some patients develop hypocalcemia, hypomagnesemia, or hyponatremia, but sometimes the seizure is focal due to invasion of the brain parenchyma. This may also be a cause of epilepsy or seizure in patients with bacterial meningitis. Meningitis may also affect the vascularity of the brain, causing infarction, progressive cranial neuropathies. It may cause a very high CSF pressure, and CSF protein is elevated. This may lead to obstruction of the CSF flow. It may cause hydrocephalus. How we investigate patients who have got bacterial meningitis. Bacterial meningitis is accompanied by an elevated white blood cell count and raised inflammatory markers. So whenever you receive a patient and you suspect bacterial meningitis, you send for basic investigations. This is mandatory for all patients to have a CBC, renal function, liver function, electrolyte, because all these may be deranged in bacterial meningitis. Most importantly, any patients with suspected bacterial meningitis, before giving any antibiotic, blood culture should be sent for them, because it has been shown that 50% of patients who have got bacterial meningitis, they have a positive blood culture. The presence of septicemia may lead to thrombocytopenia. There might be hypocalcemia, hyponatremia. These are all complications that may happen, that may accompany bacterial meningitis. Renal impairment, metabolic acidosis. Imaging should be undertaken urgently to exclude mass lesion, hydrocephalus, or cerebral edema, which are a contraindication to lumbar puncture. After we do basic investigation, we send the patient, we try to do lumbar puncture for the patient, but before that we should have a brain imaging. The diagnosis of meningitis is made by blood culture, CSF analysis, staining, and culture. This is the appearance of a normal CSF or normal CSF analysis, which you took in your first lecture, in the introduction lecture. How the appearance is colorless clear. It is crystal clear. The pressure is normal. Pressure of the CSF is usually between 50 and 200 millimeter H2O. The cells are up to 5. All should be lymphocytes, no polymorph. So you see only lymphocyte. The blood sugar is about two-thirds of the CSF sugar is about two-thirds of blood sugar, and protein is between 15 to 45 milligram per deciliter. This is the normal CSF analysis, which you already took in your first lecture, in the introduction lecture. In bacterial meningitis, you see that the color becomes turbid, sometimes milky. The pressure is very high. The white BC becomes very high, up to 60,000. More than 80% is polymorph. So there will be polymorphocytic peleocytosis. Unlike viral or TB, which have mainly lymphocytic pileocytosis. In bacterial meningitis, it is polymorphocytic pileocytosis with a low blood sugar. It becomes less than 40% of blood sugar. Protein is elevated in the range of 1 to 5 grams per liter. This is a comparison actually between bacterial, viral, and TB meningitis, how to differentiate it by CSF analysis. You notice that in most of the cases, in viral meningitis, the CSF is clear. The pressure is slightly elevated. YBC is elevated, but is not as much as the bacterial. The YBC less than 50% is polymorph. Mostly it is lymphocyte. The most important and striking feature is that there is normal blood sugar, except for some viruses like mumps. The blood sugar is usually, the CSF sugar is usually normal, and the protein is elevated, but it is slightly elevated, not as much as bacterial meningitis. While in TB meningitis, the color is usually clear. It could be opalescent, and there is a spider web appearance on the surface of the CSF. The pressure is very high. White BCs are not as much as high, but it is mostly lymphocytes. What's a striking feature of TB meningitis is that the blood sugar is very low, and the CSF sugar is very low, and the CSF protein is very high. So whenever you face a lymphocytic pileocytosis with a very low CSF sugar and a very high protein, you suspect TB. How we treat a patient in general, patients with bacterial meningitis. The first priority is to commence empirical antibiotic, because we don't get the results immediately. After we take the blood culture, we do CT of the patient or brain imaging. Later on, we do lumbar puncture. We will not wait the result of the lumbar puncture. Immediately, we should start empirical antibiotic therapy, because meningitis is a life-threatening situation. You cannot wait for example, 24 hours till you get the result of the CSF. That's why it's better to immediately commence empirical. Empirical يعني كورانا جاري دولنيانين كوزاكيتشيا. We give antibiotic. Empirical therapy in the absence of staining and culture depends on age, immune status, and any other risk factor. In a healthy, immunocompetent adult, treatment should be initiated with third-generation cephalosporin and vancomycin. So this is our regime. Our strategy is give third-generation cephalosporin and vancomycin. In most of the cases, we give this treatment. If we suspect Neisseria meningitis, usually the first dose should be benzalpenicillin. This is given in an outpatient basis. If a patient with Neisseria meningitis, suspected Neisseria meningitis, went to an outpatient clinic, and there they suspected this infection, they usually give a first dose of benzalpenicillin and send the patient to the hospital. In hospital, the management differs usually. If there is a nosocomial infection following surgery or trauma or recurrence of shunt, ceftazidime is the preferred treatment. Ceftazidime is very effective against the gram-negative Pseudomonas aeruginosa. This is why we start ceftazidime. This is the empirical treatment, as we said, before getting any result. In preterm infants and up to 3 months, usually we give ampicillin plus third-generation cephalosporin, a combination of ampicillin and third-generation cephalosporin. Why we give ampicillin with third-generation cephalosporin? To cover for listeria. In an immunocompetent patient, usually a third-generation cephalosporin with vancomycin is given. In any adult who has a debilitating illness, or he is alcoholic or immune compromised, apart from third-generation cephalosporin and vancomycin, we also add ampicillin to cover for listeria. If it's caused by a surgical problem, for example, post-traumatic or post-neurosurgery, we don't give ceftriaxone or cefotaxime. We give ceftazidime plus vancomycin plus ampicillin. This is the empirical therapy. Specific therapy differs. In Neisseria meningitis, usually it is a third-generation cephalosporin for 7 days. Alternatively, we can give benzalpenicillin. If he is allergic, chloramphenicol may also be given. Streptococcus pneumonia, the treatment is third generation cephalosporin for 2 weeks. Unlike Neisseria, in Neisseria only we treat for 1 week, plus vancomycin. H. influenza, we give ceftriaxone for 2 weeks or ceftazidime, cefotaxime for 2 weeks. So in H. influenza, we treat by third generation cephalosporin for Listeria, how we manage listeria, a patient with listeria monocytogenes. We give ampicillin or amoxicillin for 3 weeks, plus gentamicin for 1 week. Alternatively, if the patient is allergic to penicillins, we can give cotrimoxazole. But usually the standard treatment of listeria is by giving ampicillin or amoxicillin for 3 weeks, then gentamicin for 7 days. Staphylococcus aureus, the treatment is vancomycin for 1 month. Pseudomonas, we give, as we said, ceftazidime plus gentamicin. The ceftazidime is for 3 weeks, and gentamicin usually is continued for 1 week. Alternatively, we may give meropenem. Meropenem is also a very good option. Although it is widely used among our patients, it should be preserved for severe infections. But this is not the case actually in our locality. Then we talk about specific causes of bacterial meningitis. Neisseria meningitis or meningococcal meningitis, which is a gram-negative intracellular diplococci. It's the most common identifiable cause of meningitis in children. It affects about 1.1 to 1.5 per 100,000. It usually happens in the winter and early spring. Transmission, usually, as usual, it is by droplet spread. 5 to 10% of all adults are asymptomatic, so they are carriers, and they carry the pathogenic bacteria in their nasopharynx. The mortality is 25. It may rise up to 40% if it is associated with septicemia, because some patients have septicemia with Neisseria meningitis. Clinical manifestations of meningococcal infection may develop within minutes to hours. 40% of them, they only have meningitis. 10% have septicemia alone, and 50% they have meningitis with septicemia. Whenever it is meningitis alone, of course, it has a much better prognosis. In the early meningococcal meningitis, there is a diffuse erythematous maculopapular rash. What is characteristic about Neisseria meningitis is that at the beginning there will be an erythematous maculopapular rash, which eventually develops into a characteristic petechiae found across the trunk, lower extremities, in the mucous membrane, conjunctiva, and occasionally on the palms and soles of the patient. The development of meningococcal septicemia is associated with progressive vasomotor disturbance culminating into profound hypotension, tachycardia, raising respiratory rate, indicating pulmonary edema, or raised intracranial pressure resulting from cerebral edema. So meningococcal meningitis may also present with shock and septicemia. Sometimes it damages the adrenal gland. This is called Waterhouse-Friderichsen syndrome, which is a form of fulminant meningococcal disease in which severe septicemia is complicated by bilateral hemorrhage into the adrenal gland. DIC may happen, and the patient may enter into a coma. This picture shows the rashes, the maculopapular rashes. In some area, the petechial hemorrhage has happened, but in other areas, we only see the maculopapular rashes. Whenever you see this picture associated with feature of meningitis, headache, fever, neck stiffness, you suspect meningococcal meningitis. Another picture of the petechial hemorrhage that happens in patients with meningococcal meningitis. Patients, how we manage such cases. Patients with probable fulminant meningococcal meningitis should be treated immediately in a primary care with parenteral benzyl penicillin 2.4 gram intravenously. So they should receive the first dose of antibiotic in the primary care when they are there is a high index of suspicion. They should be transferred immediately to accident and emergency. Treatment, the first line, as we said, is third-generation cephalosporin for 7 days. Alternatively, we may continue with benzalpenicillin. Antibiotics should be given prior to any diagnostic procedure if there is a petechial or peripheral rash or shock. So immediately we should start antibiotic. We should not wait for the result of investigations. Septicemic shock should be treated with appropriate volume replacement. Intubation may be needed. The patient, of course, this is the management of all types of meningitis. Whenever there are complications, you treat the complications accordingly. For example, renal impairment, electrolyte disturbance, shock, thrombocytopenia, coagulopathies, all should be treated accordingly. And if there is sign of CSF obstruction, raised intracranial pressure, also they should be managed in the intensive care accordingly. Sometimes a surgical intervention may also be needed, like a drain if there is a severe raise in intracranial pressure. Meningococcal meningitis is a notifiable disease. So whenever you diagnose a patient with meningococcal meningitis, it should be notified to the authorities, and there is a high risk of family member developing the disease. So the family members should receive a prophylactic antibiotic to eradicate any nasopharyngeal carriage and also to cover up for the development of infection. It is recommended that rifampicin 600 mg twice daily should be given as a prophylaxis for 2 days. Alternatively, ciprofloxacin 750 mg may be given as a single dose. So any contact or household with this patient should receive antibiotic. Meningococcal vaccination is now available. The vaccine will give protection for 3 to 5 years and may be of value in controlling outbreak. Usually the outcome nowadays is better than previously. Complications of acute infection are common. It occurs in more than 35% of patients. They include cerebral edema, hydrocephalus, vasculitis, venous thrombosis, ventriculitis, labyrinthitis, and spinal cord involvement. Mortality rate is still about 25%. It may rise to 40% in cases of septicemia. Of survivors, 20% have neurological sequelae, such as hearing loss, loss of limbs secondary to large vessel vasculitis, neurological disabilities resulting from cerebral ischemia. The second type of meningitis, which is the most common type of bacterial meningitis in adults, is Streptococcus pneumonia. It accounts for 50% of all cases of bacterial meningitis above the age of 18. The organism is a gram-positive coccus. It spreads by respiratory droplet as usual. The primary site of colonization is nasopharynx. Streptococcus pneumonia is commonly caused by local extension from otitis media, paranasal sources of infection, or following a fracture in the base of skull. As we said, in fracture base of skull, the cause is Streptococcus pneumonia. It's not staph. Other predisposing factors include pneumonia, alcoholism, diabetes, immune deficiency states, for example, splenectomy or hypogammaglobulinemia. Clinical presentation is similar to other forms of pyogenic meningitis, but a coexisting pneumococcal pneumonia may be present. Sometimes a patient comes with pneumococcal pneumonia complicated by meningitis. The course may be aggressive, with a rapid progression to coma and respiratory arrest. Residual neurological sequelae are common and occur in 35%. See that the complication of the neurological complication or the long-term neurological complication of Streptococcus pneumonia meningitis is higher. It's actually one of the highest causes of neurological complication. If you compare it with meningococcal meningitis, it may cause hydrocephalus, vasculitis, venous thrombosis, labyrinthitis, spinal cord involvement. This may lead to decreased intellectual function, memory impairment, seizure, hearing loss. Hearing loss is one of the major problems in patients with Streptococcus pneumonia, dizziness and gait disturbance. How we treat cases of streptococcal meningitis. As we said previously in the previous slides, we give third generation cephalosporin plus vancomycin, for example, ceftriaxone and cefotaxime plus vancomycin for 2 weeks. But there is an important treatment which should be given only in cases of streptococcal pneumonia meningitis or pneumococcal meningitis. It has been shown that if an adjunctive steroid is given to these patients, we will reduce the morbidity and complications significantly. Usually, dexamethasone 10 milligrams 6 hourly is given for 4 days, but this treatment should be commenced prior to the antibiotic treatment or just with the first dose of antibiotic treatment, because whenever pneumococcal meningitis happens, it will lead to release of the excitotoxins. These excitotoxins will damage the brain. This is why many complications happen. So it has been recommended to give dexamethasone for 4 days, which will improve the outcome and reduce morbidity in patients with pneumococcal meningitis. H. influenza is now not a common disease, actually. It's a gram-negative coccobacillus. It was previously the most common cause of bacterial meningitis in children, and it had a fatality of 5%. Meningitis occurs as a consequence of respiratory droplet spread. The primary treatment of H. influenza is third-generation cephalosporin, ceftriaxone or cefotaxime, because of the significant incidence of penicillin resistant strains. For up to 40% of patients have penicillin resistance. Chemoprophylaxis is also given for the household contacts. We give prophylaxis of rifampicin once daily for 4 days. Vaccination is recommended for all children, with first dose being given at 2 months. So now, because of the vaccination, H. influenza is not a common disease. Listeria monocytogenes. This is a beta-hemolytic gram-positive rot with 12 subtypes based on antigenic properties. The overall fatality is 15%. Outbreaks are associated with contaminated food, including soft cheese, unpasteurized milk, and occasionally raw meat. Listeria monocytogenes, as we mentioned in the previous slides, usually affects patients who have a low immune system. Predisposing factors include pregnancy. In pregnancy, always think of listeria. Advanced age, immunosuppression, and it is particularly common in patients with malignancy, renal failure, or following organ transplantation or steroid treatment. Listeria may cause a meningitis or meningoencephalitis, but seizures, disturbance of consciousness, and movement disorder may also happen. What is characteristic about Listeria monocytogenes is that about 20% of patients with Listeria monocytogenes may present with lymphocytic pileocytosis, which means that although it is a bacteria, when we do CSF analysis for such cases, we see that the majority of the cells in the CSF are lymphocyte rather than neutrophils. So 20% have lymphocytic pileocytosis. The second characteristic feature of Listeria monocytogenes is that a brainstem encephalitis may develop. It's called rhombencephalitis. This syndrome is called rhombencephalitis. Rhombencephalitis. My handwriting is not very good. So this rhombencephalitis happens in 10% of patients who have got Listeria monocytogenes. It will lead to progressive pontomedullary involvement, multiple cranial neuropathy, pyramidal signs, or sensory signs. So by these two features, we may differentiate Listeria monocytogenes. Treatment is ampicillin or amoxicillin for 4 weeks plus gentamicin for 7 days. We may also give cotrimoxazole if the patient is allergic to penicillin. TB meningitis. Mycobacterium tuberculosis is a is aerobic non-spore forming bacillus, as you know. It can be cultured by the Ziehl-Neelsen stain. Infection occurs by person-to-person droplet spread. The organism is inhaled into the lower portions of the lung and there multiplies locally before disseminating through lymphatic and hematogenous spread into other organs. Tuberculous meningitis develops secondary to a caseating tuberculous focus adjacent to CSF. This is called rich foci. These usually develop following prior hematogenous dissemination of Mycobacterium in the absence of pulmonary TB. Most of the cases who develop TB meningitis, they either have miliary TB or they have previous pulmonary TB. It's very uncommon to see a patient with pulmonary TB, active pulmonary TB, who develop TB meningitis. Tuberculous meningitis is characterized by inflammatory meningeal adhesive exudates leading to a florid small and medium vessel vasculitis, which culminates in occlusion of cerebral arteries and infarction. TB has many complications. Usually it affects the base of the brain. It produces a grayish exudate in the meninges. It may invade the cranial nerves. It may cause multiple cranial neuropathies. It may involve even the spinal cord, causing radiculopathy. It may invade the bases of the major arteries of the brain. It may cause vasculitis or even cerebral infarction. It may cause spinal cord block. Because of the very high protein content of the CSF, it may cause CSF obstruction and hydrocephalus. It has so many complications, and it's a subacute illness rather than acute illness like, for example, streptococcus pneumonia meningitis. There is also a disturbance of CSF flow, as we said, impairment of the absorption of the arachnoid villi, blockage of the aqueduct. It may cause hydrocephalus. Vasculitis is also common. It invades the arteries at the base of the brain. Usually it affects the proximal portion of the internal carotid artery, proximal middle cerebral artery, perforating vessels of the basal ganglia, and internal capsule. So it has many complications and many. TB meningitis is often preceded by a prolonged prodrome of non-specific symptoms like malaise, anorexia, low-grade fever, myalgia, photophobia, and headache. The patient may present with these symptoms for up to 2 weeks. Then he will develop features of meningitis, which is usually insidious, associated with worsening headache, nausea, vomiting, focal or generalized seizure, progressive impairment of consciousness. The most common cranial nerves which are involved are the extraocular, the one that supply the extraocular muscles. Third, fourth, or sixth nerve palsy may be seen. It may also affect the facial nerve. It may cause optic neuropathy. It may cause hearing loss, bulbar involvement. Fundoscopy may show papilledema because of the very high protein content of the CSF. This will cause raised intracranial pressure, and it may cause papilledema, or due to obstruction. It may happen due to obstruction of the CSF flow. It may cause optic atrophy, and choroid tubercle may be seen by fundoscopic examination. It may cause hemiplegia or hemiparesis, so the patient may present with stroke or a space-occupying lesion. By the way, in this lecture, we are just talking about TB meningitis. We are not talking about TB of the brain, because there is also another entity which is called TB of the brain, whenever the TB invades the parenchyma of the brain, and forming space-occupying tuberculomas inside the brain parenchyma. Movement disorder may happen whenever basal ganglia is involved. Cerebrovascular disease usually occurs in the distribution of the anterior circulation and may be posterior in distribution. How we diagnose a case of TB meningitis? The diagnosis is somewhat difficult. Usually it depends on the epidemiological area. Some areas are endemic in TB. So whenever a case comes with subacute meningitis and lymphocytic paleocytosis in the CSF, a high index of suspicion should be put on such cases. But definite diagnosis is somewhat difficult, so we have to depend also on clinical feature and some important investigations. Tuberculin test is usually not reliable and variable in response. CSF examination will show the lymphocytic peleocytosis, very high protein and a low sugar. Direct examination of the CSF for acid alcohol fast bacilli requires a provision of large volumes of CSF, and it is experience dependent. So even CSF, if we send it for acid fast bacilli, we may not get the results. Why? Because we may need to do the CSF several times, and we may take large amounts of CSF so as to get the result. It has been shown that only 10% of the cases will get the acid fast bacilli. So it's not also dependable. If we talk about culture is positive in 10 to 60% of the cases. But the problem with culture is that it requires up to 6 weeks, and therefore it's of only limited value in clinical practice. There are two other new tests which are very important for the diagnosis. One of them is called nucleic acid amplification technique. It's 98% specific, but the sensitivity is low, while CSF PCR, polymerase chain reaction, is highly sensitive. So the best way to diagnose TB meningitis is that we combine nucleic acid amplification technique plus CSF PCR. If we do these two, we will get a very high specificity and sensitivity for the diagnosis. Radiology of patients with TB meningitis. Approximately 50% of patients with TB meningitis may show evidence of previous TB on their chest X-ray. So whenever you suspect a patient with TB meningitis, when he comes to the emergency department, you do the routine investigation, as we said, the renal function, the liver function, CBC, ESR, CRP, the electrolytes, and you send also for chest X-ray. Chest X-ray may show previous TB. 10% may have miliary tuberculosis, but active pulmonary TB is not common. Brain CT and brain MRI are very helpful for the diagnosis of TB meningitis, but MRI is much sensitive in showing the meningeal enhancement, the focal abnormalities, if there is a tuberculoma inside the brain parenchyma, if there is obstructive hydrocephalus. These information are usually more obtainable by MRI, but urgent CT is also very helpful. It may show hydrocephalus, it may show signs of infarction or even enhancement. The brain MRI of a patient with TB meningitis, we see that there is enhancement at the base of the brain. We manage patients with tuberculous meningitis. The management is somewhat different from pulmonary TB because the course of treatment should be very prolonged. Usually the treatment is commenced with 4 drugs: INH, rifampicin, pyrazinamide, and ethambutol. These 4 drugs are given for 2 months. And this should be followed by 9 to 12 months continuous phase of treatment with INH and rifampicin. So we give treatment for more than 1 year. The first 2 months we give 4 drugs. Later on, for 9 to 12 months, continuous phase of treatment is with INH and rifampicin. All antituberculous drugs carries a significant toxicity, as we know. Steroids are indicated in certain conditions. Sometimes a patient with TB meningitis may require steroid treatment up to 3 months. These steroids are indicated if there is cerebral edema, spinal block, severe tuberculous meningitis, spinal arachnoiditis, or vasculitis. Whenever there is sign of vasculitis or there is obstruction of the CSF flow, spinal block, steroid may be needed under the umbrella of anti-TB drug. we don't give steroid alone. It should be under the umbrella of antituberculous drugs. Surgical intervention sometimes is required for obstructive hydrocephalus. The outcome of TB meningitis has remained poor, and the mortality is still more than 20%. And there is severe neurological sequelae occurring in 30% of the survivors. So the mortality rate so far is very high. These are the drugs which are used for tuberculous meningitis. Each has specific side effects, and we should know about the side effects because we are giving these treatments for a prolonged period of time. One of them is INH, or isoniazid. Isoniazid, by the way, most of these drugs affect the liver, so a liver function test regularly should be sent for such cases because it may cause hepatitis. It may affect the hematological system of the patient. It may cause hemolytic anemia, aplastic anemia. Also, it may affect the nervous system. One of the complications of INH is peripheral neuropathy, optic neuritis. Even psychiatric manifestation of INH, like mania, or even it may cause fit. So patients with isoniazid, because we are giving the treatment more than 1 year, they should receive pyridoxine or vitamin B6 to avoid peripheral neuropathy. Another drug is rifampicin, the second drug. These are the essential drugs that should be given for all the patients. Rifampicin may cause hepatitis, thrombocytopenia, headache, confusion, and drowsiness. Pyrazinamide also may cause hepatitis. Look, hepatitis is present in almost all the anti-TB drugs. Ethambutol is the fourth drug which is given. It may cause retrobulbar optic neuritis, peripheral neuropathy. We have some other alternatives. Sometimes we may give streptomycin or ethionamide. These are all other drugs which are used for the treatment of TB meningitis. We are finished with the first part of CNS infection, and next week we will continue with CNS infection. We try to cover the other subjects. Thank you very much.